Good afternoon and welcome to today's webinar, Building a Culture of Quality, the Imaging Professional's Role in Ensuring Patient Safety. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will be monitoring questions throughout the presentation, and we'll try to answer as many of them as possible during the Q&A period. Also on the left side of your screen is the Resources tab. Click on this tab for links to today's resources, which include a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during the course of this webinar, you may click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ASRT CE credit, you must be registered, logged into this webinar, then complete the survey. The survey will open automatically at the conclusion of the live session and be available from the IAC Pro Libraries website for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. And now I would like to introduce today's guest speaker, Ms. Rosemary Gibson. Ms. Gibson is the Senior Advisor at the Hastings Center and Perspectives Editor for JAMA Internal Medicine. She is an award-winning author, speaker, and passionate advocate for quality and patient safety. She serves on the MedStar Health System Institute for Quality and Patient Safety Advisory Board and is board chair of the Alterum Institute, a nonprofit health systems research organization. Previously, she designed and funded national quality improvement initiatives while at the Robert Wood Johnson Foundation. Ms. Gibson is a past recipient of the highest honor from the American Medical Writers Association for her contributions to the field of medical communication, and we are honored to have her with us today. With that said, I will now turn the webinar over to today's speaker, Rosemary Gibson. Rosemary?
Thank you very much, Kelly, and good afternoon, everyone. It's really a joy to be here. This is a webinar that involves you and your professional role in ensuring patient safety. And just to reiterate, the title of today's presentation is about building a culture of quality and what your role can be, whether you're a technologist or if you're a sonographer or a physician or administrator. This webinar is about how you can achieve better outcomes for your patients and your facilities and practices every day. We have 3 objectives for today. We're going to talk about a patient experience, a real case, published in JAMA Internal Medicine on quality imaging. And that case will frame the rest of our discussion today. And second, we'll recognize how every aspect of the healthcare provider's patient interaction affects patient safety, from the quality of the image to writing an accurate report. It's about tracking and looking at every step along that continuum of work. And third, we'll share the 4 components of quality imaging from IAC and how you can use them to help your facility continuously improve. So for an overview for our next 45 minutes of presentation, this will be a case of a patient with tremors, and it comes from a leader in the field of quality imaging. And we'll talk about the source of that we published in JAMA Internal Medicine. We'll talk about the 4 components of quality imaging, and then we'll talk about culture, and just culture in particular, and how it can improve imaging quality in your work environment. And finally, we'll be closing with a few reflections, and then we'll turn it over to Q&A. our case today is about a real patient with tremors. This is a case that, as an editor at JAMA Internal Medicine, I invited someone from the imaging quality community whom I've known, a true leader, who shared an experience in her family with her husband. And we published it because it was a really compelling story. And it's absolutely relevant to our discussion today about improving quality in imaging. This was a 69-year-old retired telecommunications company employee, and he went to his longtime primary care physician. He was very concerned about tremors in his hands. He had noticed these symptoms for about 2 years. And as the author wrote in her piece, one night they flared up while he was carving a ham. Sometimes he needed 2 hands to hold a cup of coffee. And when he was writing, certainly the tremors had the most visible impact. And of course, what immediately comes to mind for many people is the fear of Parkinson's disease. So they wanted to check it out. This is the article that was published, and Kelly has provided everyone with a link. It's a very short piece. It's just 1 page, but it tells a very compelling story. So the primary care physician ordered a DAT scan, a dopamine transporter scan, at a local hospital. And so the husband and wife went to that local hospital and had the test. The patient had a radiopharmaceutical agent injected in the veins in a procedure called SPECT imaging. When time came to interpret the results, the primary care physician read them and said the test results were normal. And the family, being very knowledgeable and involved in imaging, asked 2 nuclear medicine physicians who are experts to also read the scan. And this is where the challenge appeared. One concluded that it was normal, and the other believed it showed early signs of Parkinson's disease. So diametrically opposed interpretations. When this happens, patients can feel a very substantial burden. In this case, the patient and family were very worried about what a Parkinson's diagnosis would mean for their quality of life. And the case illustrates the point that when patients come to your practice, they may be terrified, fearful of a diagnosis being found or realizing that a life-threatening disease has returned. In this case, the author of this narrative in JAMA Internal Medicine reports that her husband hated going for tests. But he knew he had to do it, and he did it. And what are some lessons for us? Now, here's our first poll. In question number 1, what would you do if this were you or a family member and you were in this situation? If you went for a test and it came out with diametrically opposed results? Here are 3 answer choices. Would you ask another doctor to review the scan? Would you conclude that Parkinson's disease is hard to diagnose? Or would you ask that the test be done over again? Now, 72% of those of you who responded today said you would ask another doctor to review the scan. Another 7% would say that Parkinson's disease is hard to diagnose. And 20% would ask to have the test done over again. These are all very realistic responses that patients and families have to test results that are inconclusive or conflicting or just hard to interpret. So thank you for taking that poll. We'll have several more in the course of this presentation. It turns out that none of these choices would have been optimal. None of them would have solved the underlying issue and imposed the least burden on the patient. And here's why. This very highly engaged and informed family wanted answers, so they contacted a nuclear medicine specialist who went back and reconstructed the raw data from the camera at the hospital. And he and 2 additional colleagues reviewed and discussed the study. So a total of 3 nuclear medicine specialists did this for this family. And here's what they found. It's very interesting. When they looked at the raw data, they found that the patient had not been properly positioned during the exam. The husband's head was slightly tilted and rotated during the test, and that made the image really hard to interpret. And so what was the end result of the report? The 3 nuclear medicine specialists didn't agree that the study showed Parkinson's disease. They concluded instead, good news, that the results were probably normal. They also said that the 2 physicians who had reviewed the results earlier may have seen only screen captures and not the raw projection data. And so they could not have caught the asymmetry in positioning. Here's another question for you in our second poll question. How often do you think it occurs that patients are not properly positioned during an exam? And there are 4 choices here. 1, it probably happens more than we know. 2, it's not a big problem. 3, it's probably rare or never. And 4, we don't know because retrospective self-assessments are not usually performed. 85% said it probably happens more than we know. Very few think it's not a big problem. 1% only rarely or never. And 11% of you said, don't know because retrospective self-assessments are not usually performed. And that latter answer option is what we'll be talking about today in our discussion of quality improvement and quality imaging. Let's keep going. In this case, the downstream effects for this patient were very significant. He was faced initially with an uncertain improper diagnosis. That additional waiting time caused anxiety for the patient and the family. The resource consumption was very significant. There were 5 nuclear medicine physicians who participated in the review, and they did it as a professional courtesy. And the cost of the test when the family got the bill was more than $5,000. It was actually $5,700, and that was billed to Medicare, but they still had a very substantial copay. Here's another poll question for you, number 3. What do you think is the top reason patients are not positioned correctly? And I realize there might be more than one answer to this, but what do you think is the top reason? And here are your 5 choices. The first, the patient isn't compliant with instructions. The second is there are inadequate instructions that the patient's given. Third, the staff are not fully trained. Fourth, the protocol needs to be improved, or perhaps something other. So here are our results. Very interesting pattern, sort of spread across the different answers. You reported patient noncompliance with instructions. 28% of you thought that was the top reason. 30%, this has got the most votes, 30% of you thought that there's inadequate instructions provided to the patient. 16% reported that staff are not fully trained. 13% said the protocol needs to be improved as the top reason. And 10% of you said other. So there's a lot of variation here, and chances are each of these factors plays a role when patients are not positioned correctly. Very interesting findings. So here's question number 4. How often do you think practices receive feedback when image quality is an issue? So let's assume an image is done, report written, goes back to the referring physician, goes further downstream, maybe results in a surgery or other treatment. And then there's a realization that image quality was an issue. Do practices get feedback? Do they learn about that? Because imaging is very much upstream and so many other things happen downstream, is there a feedback loop that brings issues back up when there is a concern about image quality? So there's 4 choices here. The first is all the time. Practices receive feedback when image quality is an issue. Sometimes. Third option is rarely. Fourth possible answer, not sure. So, how often do you think practices receive feedback when image quality is an issue? 6% of you thought all the time. 41% say sometimes. 48% responded rarely do practices receive feedback, and 4% not sure. It seems that there's opportunity, based on the poll results, for improvement about getting feedback about image quality. If we add up the sometimes and rarely, that's nearly 90%. Let's move on to the next question. And this is about your practice and what you think getting feedback would mean for image quality in your practice. Do you think it would foster improvement? There are 3 choices here. The first answer is yes. Second is maybe. And third, not sure. So here we are. 90% of you said that feedback on image quality could foster improvement in your practice. 1% said no. 7% said not sure. I think what's very helpful about the responses here is that feedback would foster improvement, and we know from the earlier results that feedback often doesn't happen, either sometimes or rarely, about 90% of the time. So it seems like there's a real opportunity here for improvement around image quality and getting feedback. So after reviewing the case of the gentleman with tremors, and I'll tell you what happened to him at the end of this presentation, I'd like to move now to what are the 4 components of quality imaging and how you can help get feedback on image quality in your practice. But first, let's have a way of thinking about quality imaging, stepping back and taking a look. You know, when everyone goes to work every day, we all want to do the best job. And most of us think we're doing our best, whatever job we do. But how do we know that we're really doing a good job? How do we really know? Oftentimes, the only way we really know is if we have a chance to go back and look objectively, thoughtfully, when we're not under time pressure, and reflect on the quality of our work. So let's bring this closer to home with your practice. How likely is it that the loop would be closed and your practice would discover an incorrect positioning of a patient that caused uncertain test results? There are 4 options here for answers. The first is very likely that your practice would discover an incorrect positioning of a patient that caused uncertain test results, that the loop would be closed. The second answer is, well, maybe. The third possible answer is not likely at all. Or fourth, not sure. Okay, we see across the board here responses. So 26% of respondents today said that it would be very likely that your practice would discover an incorrect positioning of a patient that caused uncertain test results, that the loop would be closed. 26% now, 43% said, well, maybe we would discover it. 20% not likely at all. 9% not sure. So there's a lot of variation here, And if we add up the maybes, not likely at all, that brings us to 63% plus not sure, 10%. That's almost 3/4 of you said that your practice, it's unclear that it would discover an incorrect positioning of a patient that caused uncertain test results. So what can be done to allow that discovery, to know if what you're doing is really good quality imaging? How can you find out the frequency and other of improper patient positioning in your practice and other opportunities for improvement? You know, the word quality improvement has many meanings. It can seem very complex, but the concepts are really simple. It's by looking at the work we do, learning how the work gets done, and identifying a way to do it better. Here are the 4 components of quality imaging. First, the appropriateness of the test. And we'll come back to each of these in just a minute. Then there's the technical quality. There's interpretation quality. And finally, there's the final report completeness, accuracy, and timeliness. Let's go through each of these. And we're going to go through each of these by doing a sample self-assessment using the story of our patient with tremors, the 69-year-old husband of a leader in the imaging community. So let's look at appropriateness. For the patient with tremors, the appropriateness of the test is not certain and was probably unnecessary. One way to identify inappropriate use is to look for outliers and patterns across different patients. Perhaps they're referral patterns that you see that may suggest unnecessary testing. Technical quality. In this case, the quality of the test performed was poor because of the patient positioning. And the patient positioning was not correct for what could be a number of different reasons. Patient compliance, inadequate instruction, improper protocol, staff training, or other factors. In effect, what we're doing here is a little root cause analysis of the case of our patient with tremors. Interpretation quality. That's the ability to accurately interpret the test findings. In this case, was not possible because of the quality, technical quality issues. Report completion and timeliness. Here, in this case, there was the inability to accurately interpret the test findings, and that made it difficult to write an accurate report and give guidance to the patient, family, and referring physician. So those are the 4 components of quality imaging. How to improve quality? It's by systematically looking at the work we do, how it's done, and how we can do it better. And all of us in our life, no matter what we do, we can always do it better. But how do we know what we can improve that would have the biggest payoff? And in this case, in terms of better image quality and downstream better patient outcomes. One of the sources of inspiration for the quality improvement in healthcare field is Dr. Paul Batalden. He had this wonderful quote in a British Medical Journal article. And he says, everyone in healthcare really has 2 jobs when they come to work every day: to do their work and to improve it. That all of us are part of it. It's not about relying on just a quality department or safety department to do the improvement, but it's about all of us. And for those of us who are doing the work, we know how it gets done. And we're the ones that know that work the best And with good data, we can see where we can do it better. How to improve? It's the combined and unceasing efforts of everyone, healthcare professionals, patients, and their families, to make changes that will lead to better patient outcomes, better system performance, and better professional development. But how do we know that if we change things, that we're actually making care better? And Dr. Batalden and colleagues say to know that change is producing improvements, we need accurate measurement of what is happening. We need to measure our work. If we can't measure it, how can we improve it? How to measure? IAC's quality self-assessment tool is available for facilities to use. You can assess your own performance. You can do it anonymously. You can track your progress over time and compare it with others, benchmarking. And that way you can see in a very safe way how we're doing, where we may stand out. Parts of our practice may be off the charts in terms of quality, but in other areas there's room for improvement. And that's typically the case in every practice. Rarely is it true that everybody gets everything done well. There's always room for improvement. And what can we learn from those who are doing some aspects really well? And what can they learn from us for good work that we might be doing? And that's what the aim of accreditation is. It's to help you look at what you do, how you do it, and how to improve it. I want to give a very practical example of how measurement has improved dramatically one aspect of patient care. For decades, hospitals never counted central line associated bloodstream infections. And we never tracked them over time. And plus, they were considered as things that just happened. And they were, inevitable. Infections just happened. No way to avoid them. Hospitals never benchmarked how many infections they had compared with their peers. It turns out that central line infections have resulted in thousands of deaths each year, yet these infections are preventable. And there are tools out there now from the CDC and others, the Centers for Disease Control and Prevention, to help prevent them. And I always think it's important to add a human dimension to our work, the patient. This is a young woman who went in for a surgical procedure, and during the course of her hospital stay, she acquired a central line associated bloodstream infection. She was pregnant. That's her infant daughter there who had just been born. The mother had been in the hospital for 4 months with this infection and other complications from it. And she ultimately succumbed to that infection. And this was the first and only time she held her infant daughter. But what can we do to prevent these? It turns out hospitals have learned that infections can be prevented and how to prevent them. There were studies reported in the medical literature that they were not inevitable. Then they started counting them, tracking them, and benchmarking themselves with other facilities. And here's an example of what happens when hospitals measure central line infections. You can look for trends. These happen to be Kaiser hospitals comparing themselves to other hospitals in the state. This is information now that's out there publicly. At first it was done privately, anonymously, but now we're sharing it and learning. It's sort of an inspiration to do it better. And so the result, the number of people dying from central line bloodstream infections in America's hospitals has been reduced. More people are going home from the hospital alive to be with their families, to celebrate birthdays and weddings. And this is why healthcare professionals, all of us, go to work every day. We want to do it better. It's the tools of quality improvement that help us do it better. By measuring the quality of imaging, facilities can help people receive better care. Just a word about what QI is not. It's not a checklist. It's not just checking the box and going through, yes, we've done this, yes, we've done that. And really importantly, QI is not about pointing the finger. This is not about blaming anyone. This is about just taking a look at our work and objectively observing how can we do it better. It is asking, how are we doing? How can we improve it? As you proceed with quality improvement in your facilities, it's important to think about the culture and how you go about doing it. And there's an emerging theme in healthcare today called just culture. Culture is not something that we see, but it's something that's very present in every work environment. And just culture matters. And here's an example of how we need to do it better in so many other aspects of our lives. This is a train crash, an Amtrak train crash photograph that was taken last year when an Amtrak train was traveling along the Northeast Corridor, and just after it left Philadelphia was going over 100 miles an hour, faster than the allowable speed, and it crashed. People were killed and injured. And this was what happens when just culture isn't present. This got into the media. The Amtrak train crash cause, according to the mayor, was that the engineer was reckless. This was on the newspapers and the headlines, and the mayor came out ahead of anyone else and said, well, we're going to blame this engineer. Fortunately, right after that, the National Transportation Safety Board, which came to investigate this crash, which it always does, whether it's airplanes or, in this case, trains, criticized jumping to conclusions and pointing the finger. And if you look at the subtitle of this article, it says, Official Urges Fact-Based Unemotional Investigation. Just going to look here. We're not going to blame. One of the founders of the quality improvement and safety field in healthcare today is Dr. Lucian Leap. He's a retired pediatric surgeon, and he told Congress that the single greatest impediment to safety and quality is we punish people for making mistakes. Everyone makes mistakes, and many of us, when we're in healthcare, the same thing could have happened to any of us if we were in that same situation. So we don't want to punish people for making mistakes. So what's a way to think about creating a culture that's just and fair? Just culture is an appropriate response to three types of human behavior. And this is from the work of David Marks and many others who are trying to create environments in which we can report unsafe situations or concerns about quality. So there's human error. That's the first type of human behavior, and that's when there's something inadvertent. It's a lapse or a mistake. Anyone in the same position could have made the same mistake. I think of when I'm driving around my home and there's a speed limit of 30 miles an hour, and then you go down a hill and you accelerate automatically without putting your foot on the pedal. As a result, I'm speeding. A lot of people in that same position could make that same mistake. The appropriate response there is to console in the case of a concern about quality in the healthcare setting. A second human behavior is risky behavior. That's when there is a decision made to act in a way that increases risk, where the risk isn't seen or is mistakenly believed to be justified. So if I deliberately put my foot on the accelerator because I'm late for picking up my child from daycare, and I'm taking a risk, we knowingly do it, that's a concern. That requires coaching. And then there's reckless behavior, and that's where there's conscious disregard, a substantial risk will harm a patient. And there, other types of action should be taken that really is punitive. But unfortunately, we use the punitive response for what are mistakes that anybody could make in a busy practice. And that's not just culture. So how do you create an environment where, and a culture, where people are rewarded, our people are honored, that we support those who work to improve quality. Here's a simple tip that healthcare facilities are using that help raise awareness and honor and celebrate good work that people do. One idea is every month recognize a staff member who is mindful about quality or made what's called a good catch. That's a good catch. That's a person who's skilled, who's trained. Often the good catches in healthcare, we can't take a picture of them because they're often cognitive. But I'm sure you do good catches all the time in your practice. So how can we honor that skill, that talent, and that commitment? That's something that you might consider doing once a month or quarterly to honor a staff member who's particularly conscious and engaging in quality. So in closing, we've covered a lot of ground, and I'll just recap. In this presentation, we reviewed a patient case. This was a 69-year-old gentleman with tremors. Very fortunately, his wife was very active in the imaging quality field, and she was able to bring skilled physicians, skilled nuclear medicine specialists to have the best of their advice, and they realized that in fact it was an improper positioning of the patient. We learned from the polling today that there's room for improvement, and there's a desire to have feedback about quality in your practices. We reviewed today a QI tool that can improve quality performance. And those 4 domains of quality: appropriateness of the test, technical quality, interpretation quality, and writing a complete, full, accurate, and timely report. And finally, the importance of just culture. That we go about doing this work of improving quality with a sense of fairness. And the just culture framework helps you look at different types of human behaviors in a new light. So what did happen to the patient with tremors? Well, the family went to see a neurologist. This was after the scans had been done and they showed he had no Parkinson's. But they still went to see the neurologist. And he did a very thorough physical exam, took a family history. It was about an hour. And the patient received a diagnosis of familial essential tremor of the upper limbs. He was prescribed certain medications. The family was greatly relieved that the husband did not have Parkinson's. And in the end, and this gets back to the appropriateness dimension of quality imaging, his wife wrote, "All my husband needed was a good physical exam." One of the lessons from this case, it's all about the patient and what you can do as a technologist, as a sonographer, as a physician. You can help patients have better outcomes. Image quality has an enormous downstream impact on patient care, affecting diagnosis, treatment, and so much more. And feedback loops can help you understand the quality of the images in your practice, so you can learn and you can improve. And that has a dramatic impact on patients' quality of life, the treatments they receive, the surgeries they have or they don't. I learned about the importance of this work for patients in a book I wrote, The Wall of Silence, where we share the impact of how we provide care, and sometimes when things don't go well, hearing from patients, families, and the clinicians taking care of them. So now we have a chance for questions and answers, and I hope that you'll be filling up the Q&A section here.
Hi, Rosemary. This is Beverly, and Stephanie wants to know if you have any tips or how would you recommend getting all staff on board with QI. It just seems to be a little bit difficult to try to get everybody on board and know that it's a good thing. So do you have any suggestions or tips?
Sure. Stephanie, that's a great question. One lesson from a lot of quality improvement is that there are some people who are eager and those who are less so. And one way to begin can be just with a few people who are interested. And you can start with a little pilot test, a small test of change, something that can be done next week, next Tuesday. And then document the impact that has on the practice, on image quality. And then share those results if you've had an improvement, which I'm sure you will. And if you can show that have data that shows we can do it better, that can often be an inspiration to engage others to join. If we waited for everybody who was interested to start QI, we wouldn't make that much progress. Where we have made progress is starting with those who are ready to go, passionate about it, and want to make a difference. And over time, keep sharing good results as a consequence of improvement. And then at some point, it can be made not an option. But hopefully we can invite people to the table, invite people to do this work, because it creates better patient outcomes, and you can demonstrate that. And that brings more joy and enthusiasm to the workplace. So that's how I would start. Start with what you have.
I have a question from Deborah. She wants to know, how can we get our already overburdened physicians to buy into improving quality?
One way to do that is to show the results of your self-assessment. If you can show that there's opportunities for improvement, that can often be an invitation, inspiration, encouragement to physicians who do want to do a good job. But often, as you say, there's not enough time in the day to go back and look and reflect. I'll share an example of how a very seasoned nurse engaged physicians in her hospital to implement a safety improvement intervention. She showed the physicians data where they were not doing very well on patients whom they knew, as patients whom the physician knew. And she showed data explaining this is why Mrs. Jones or Dr. Smith didn't do well. But here's what we can do to make sure that doesn't happen again. So to show physicians where we may not be doing so well, but here's a chance for how we can improvement, that can sometimes provide incentives to physicians to be engaged. And once again, not every physician will be enthused if you can find one to begin, a champion. That can be a fruitful place to start.
The next question I have is from Ben. And what and when would be the follow-up if there is indeed a problem with the initial reading, if it was peer-reviewed and there was a discrepancy found?
Well, thank you, Ben. That's a great question. I think that information needs to be conveyed to the referring physician. If the patient is undergoing treatment, and if that treatment is an error, we have an ethical and moral responsibility to inform that treating physician. It's essential that feedback be given.
I have a question from Nazmi, and she said, what do you do when you have a big organization with some staff that is more worried about their paycheck than quality?
That's a great question, Nazmi. Thank you for asking it. Again, it's not uncommon at all. And we have to start with those who are interested, those who do want to make care better. And invite them to maybe a brown bag lunch. There might be someone who wants to share the IAC QI tool, describe the opportunity. Somebody might want to take one piece of it, make the work manageable. It doesn't have to be burdensome, but start with a small piece. Do something small and see if you can improve it. And that can be a way to get people excited. We saw this, we weren't doing so well here, and by just doing 2 or 3 steps, we were able to make an improvement. People feel good about that because they do want to. Many people do want to come to work and do the right thing.
Rosemary, Christopher has kind of a question and a statement. Couldn't you show your doctors or the financial staff how improvements could lower the cost for the clinic or practice, and maybe even reduce the possibility of a lawsuit?
Oh, absolutely. Who asked that question, Bev? What's his name?
Christopher.
Christopher, that's a great question. These things have financial impact. And if you can show that, just take 1 case or 2 cases, that would be could be a very effective way to engage physicians and other members of the staff. And it's true. Some of these, if there's concerns about quality imaging, they can have a downstream effect on a lawsuit. And if we can do something to prevent that, that's advantageous not only from a financial point of view, but from a morale point of view. And plus, we can feel better about what we do every day when we go to work. But that's a terrific angle. And I will say that we're seeing a number of hospitals that when there are adverse events, and these things are going to happen. We're human. They happen everywhere, every day. The question is, how can we do it better? When we can show improvement, and when things don't go well, if we do the right thing, it can be more financially advantageous. We can actually reduce the cost of medical malpractice liability insurance, let alone fewer outlays for claims. I'd love to see that kind of work unfold, where take real case. I'd love to see a case of it. Make it blinded, anonymous. Here was a case. This is what it cost us. If we had done X, Y, and Z using the IAC self-assessment tool to have prevented that, that's real money. It's reducing the burden on future patients. It can be very powerful. So, Christopher, thank you for asking that.
I have a question from Randy. Actually, it's a 2-parter. He said, do you feel that the primary care doctor should refer the patient to a specialist first before ordering any diagnostic testing so that the appropriate tests are performed and read properly, or order the test and see what results are before referring to the specialist? In addition, as a diagnostic testing facility, how would facilities handle receiving testing orders from primary care doctors who clearly order the test not appropriate for the patient and their symptoms and the reason that the primary care doctor's diagnosis of the patient?
Great questions. On the first one, in this case, primary care physicians, the internists in JAMA Internal Medicine, when they read this narrative, they said that the patient with tremors, he should have been able to be diagnosed by his primary care physician. This should be the function of a good primary care physician. A second step, instead of referring the patient to have a test, you're right, that patient should have gone to a specialist, in this case the neurologist, and that would have avoided this unnecessary, what turned out to be unnecessary scan. As to your other question, you're pointing out a really critical issue and not easy to deal with. And this is when primary care physicians refer patients for testing that's inappropriate. One way to deal with that is if there's what is perceived as a truly inappropriate request, to give feedback to the primary care physician about an alternative course. And if there's a way to do that, that will be respectful of that primary care physician, so he or she doesn't stop referring patients to you, which is certainly what many practices want to avoid, that would be an optimal outcome. That takes time, but what's at stake is a patient undergoing an unnecessary test and the burden associated with that. A second way to handle it is to look for patterns. If you observe that there's a primary care physician referring patients for certain tests to your practice, and if you can show variation and how this physician may be an outlier, that could be valuable feedback for that primary care doctor. That takes time. It takes collecting data on your practice and the referrals, but it's the right thing to do for the patient. Thank you for asking that question. It's a really good one.
Michelle asks, she is the only MRI technologist in her office, in her orthopedic office, and she wants to know, should she review her own work, or should she get somebody else to review it? And we hear this question often because many times it's just one physician, one technologist or sonographer, so it's a little bit difficult. They're unsure how to go about doing that.
That's a great question. Thank you for asking it. I think there are two steps to it. I think you could try to do your own self-assessment. And what can you learn from that? And the second step is using IAC's benchmarking capability that's ramping up, where you can compare how your practice is compared with that of your colleagues, again, anonymously. That's another way to get feedback about your practice if you're the only person in there doing a certain function.
I have a wonderful question from Valerie. She asks, the picture of the woman holding her baby for the one and only time was very powerful. How can we bring that type of powerful message into our QI process?
It is very powerful. And I started using those pictures when clinicians asked me to show pictures of patients. One has to respect confidentiality, but it's my observation that there are patients that do want to come forward and share lessons learned with clinicians. And if there is a case that you think is really compelling, make it a good catch, and that will honor the good work that people did in your practice, then if you can use that story, blind it. Take out the name, take out any identifiers, and just use it. So one thing is to start with the patient's story, and then if there's a case where you want to ask the patient or family, if you're on good terms with them, say, we want to use this for learning. We learned it, and we want to use your story for learning. There are a number of people that would be very willing to do that. If their privacy is protected, in other cases, they're happy to have their name used, and even their photograph. And what I can do is, I'd be happy to, I know many, many people in this field in safety and quality, and I have no doubt that we can come up with photos of patients where image quality had an impact on their outcome.
I think we have time for one more question, Rosemary. And Larry says, with regard to the benchmark studies, with regards to the benchmark study concerning hospital infections, is that data readily available to the public so patients can make an informed decision on where to have an invasive procedure?
Absolutely it is. It's available on the Medicare website. It's not easily accessible, that's for sure. But one other thing that I would suggest is that you call the hospital if you know someone who's having a procedure, and you talk to those on that unit. If it's a cardiac unit or orthopedic unit, talk to the right people to find out what the infection rate is in that unit. And you'll know it's a good hospital if they know it and if they'll tell you. And if you call and they don't know it, that would be very surprising. And if they don't want to tell you, then if you have options, that might be a good thing to look into. And I know this of a woman who was anticipating surgery for cancer. She called 3 different hospitals because she happened to have a choice of where she could go. And one facility was forthright, and they told her, and it was a good rate, and that's where she went for her procedure.
Thanks again, everyone, and a very special thank you to our presenter, Rosemary Gibson. Feel free to contact IAC with questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC Pro Libraries website for 3 business days. In the upper left, you'll click on My Webinars. Look for the title of this session, Building a Culture of Quality, the Imaging Professional's Role in Ensuring Patient Safety. Beneath this title, you will see the link Take Evaluation. Click this link to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through a new link on the My Webinars page called View Certificate. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you all for joining us today and appreciate your participation.